Pleased to be the first speaker and part of a very august panel this afternoon. I'd like to thank Bayer and EYLEA for sponsoring this new symposium entitled Aflibercept, New Anti-VEGF in the Marketplace. We have a very distinguished panel which will introduce themselves as they come up. My name is Dr. Suber Wong. I'm a practicing retina specialist from the United States. I live in Cleveland, Ohio. I have a number of positions in the States with the National Institutes of Health, the American Academy of Ophthalmology, the Asia Pacific Academy of Ophthalmology, and I'm past president of the American Society of Retina Specialists. My talk this morning, this first talk, is going to set the background for the major indication for EYLEA or Aflibercept in India. I'm going to discuss the integrated View 1 and View 2 trials that were published in March of 2015, and this was an investigation of the efficacy and safety of intravitreal Aflibercept in age-related macular degeneration. This may not be recorded per the guidelines set up by Bayer and by Regeneron. Intravitreal Aflibercept has been approved by the U.S. FDA for the treatment of patients with neovascular wet AMD, for macular edema following retinal vein occlusion, and diabetic macular edema associated with diabetic retinopathy under the trade name of EYLEA. However, Aflibercept has not been approved by India's regulatory agencies for the treatment of diabetic macular edema and diabetic retinopathy, or for macular edema associated from retinal vein occlusion. This presentation will only focus on a View 1 and View 2 trial. The other speakers will bring real-life experience of using Aflibercept in the clinic. They will look at some of the more difficult cases that we see, particularly here in Asia, PCV, high myopia, other forms of neovascularization, so that will be important. As a background, we know that the fusion protein that comprises Aflibercept comes from key domains from VEGF receptors from both 1 and 2 of the human IGFC. Preclinical study shows that Aflibercept traps multiple isoforms of VEGF-A and placental growth factor and binds with very high affinity than native receptors. These are in the nano and the picomolar quantities of binding affinity, and purified formulated preparation of Aflibercept has been specifically formulated for intravitreal injection. The study design of View 1 and View 2 are very similar. View 1 was primarily in the States, and View 2 is an international study that are randomized as shown here, 1 to 1 to 1 to 1. Intravitreal Aflibercept had 3 doses, 2 milligrams every 4 weeks, 0.5 milligrams every 4 weeks, and 2 milligrams every 8 weeks. And this was compared to ranibizumab, 0.5 milligrams Q4 weeks. The primary endpoint was maintenance of vision, and dosing through year 1 was maintained, and modified quarterly dosing through year 2. The secondary endpoint was mean change in visual acuity, as shown on this slide here. Again, the primary endpoint is the proportion of patients who maintain vision, losing less than 15 letters from baseline at 1 year. And additional endpoints was the mean change in visual acuity and the proportion of patients gaining vision from baseline. The next several slides actually show that the groups are well balanced. So these are the integrated numbers. As you can see, this is nearly 2,400 patients in these 2 large studies, and each of the 4 treatment arms are well balanced, both in terms of the completion of the study, and the completion rates were between 81 and 86%. The baseline demographics were also similar, with mean age of about 78 years of age. Most of these were Caucasian, and the mean age was in View 2 was similarly distributed. The baseline disease characteristics were again similar in all the groups in View 1 and View 2, with a mix of predominantly classic, minimally classic, and occult choroidal neovascularization. The lesion sizes were also well balanced within the groups, as was central retinal thickness. At the one-year results, so you can see that in View 1 and View 2, the number of active injections were well balanced between the two groups and also reflected in the integrated group. You can see that the 2 milligrams every 8 weeks accounted for the decreased number in the yellow bars there, so they received an average of 7.5 injections out of a possible 8. So they all followed the regimen. In terms of efficacy, we were looking at the endpoint of maintenance of baseline visual acuity loss of less than 15 letters, and you can see again the integrated group that 94 to 96% maintained their vision at all dosing, similar to that of ranibizumab every 4 weeks. Mean change in baseline best-corrected visual acuity over 4 weeks were found to be non-significant for all of the groups. The one significant point was in View 1, where it was 10.9 letters gained versus 8.1 letters gained for ranibizumab. However, the subgroup analysis did not show difference. The integrated analysis did not show difference, and in the View 2 group, this difference was not maintained. So although it was interesting in the View 1 group that additional few letters were achieved with the higher dose 2 milligrams Q4, this was not maintained and not significant. The proportion of patients gaining letters was also looked at. So not only did we want to maintain vision, but how many people gained vision there. Again, View 1 and View 2 are very, very similar, and they're not statistically significant between the groups. And in the integrated group, we see that approximately 1/3 of patients gained 15 letters of vision or doubling of the visual angle. The proportion of patients who gained vision at 1 year was looked at. Most had stabilization of vision at approximately 81%. 10-letter gain or significant visual gain was at about 50%, and a greater than 30 level gain, a massive gain, was equally distributed around amongst all treatment groups. Similarly, change in retinal thickness also did not change from each of the treatment groups, whether View 1, View 2, or integrated, and that portion of patients without fluid as defined by the absence of both cystic fluid and subretinal fluid by a masked OCT reading center is demonstrated here. There was some difference here between View 1 and View 2, and the integrated numbers, however, did not show, again, statistical significance between each of the treatment groups. Safety is always a concern because safety, of course, comes first before efficacy, and in each of the groups, with subjects with at least one serious adverse event, we saw that this was relatively equally distributed around the groups, and it was interesting that ranibizumab did have a slightly higher percentage of subjects with at least one AE with 3.2% versus the lowest dose of EYLEA was at 1.8%. But these were all very, very small and not powered for looking at those events. Now, there was one side effect of these drugs that was noted, and it occurred in nearly 10% of patients as a characteristic of this kind of anti-VEGF treatment. This occurred both in the ranibizumab TRAB as well as the Aflibercept groups, and you can see that hypertension is one of the most sensitive indicators of systemic anti-VEGF action. However, there was no statistically significant difference between each of the treatment arms. And additionally, the APTC defined arterial thromboembolic events were also looked at as a matter of regulatory agency by the FDA. And again, these were well distributed, although the difference between at the lower dose at Q4 weeks versus at the 8 weeks, you can see 1% at the 2 milligrams Q4 and 2.3% at the 2 milligrams Q8. Again, it does not appear to be a dose effect, and there was not significant. Deaths were not considered an issue, and that we have much clinical data to show that these drugs do not appear to have a serious effect. But what about at 96 weeks? At 96 weeks, we look at efficacy and the proportion of patients maintaining vision, less than 5 ETDRS letters lost, and again, well distributed with only a slight decrease in the percentage of people maintaining vision. The mean change in visual acuity similarly distributed, and that each of the four groups, when compared to ranibizumab, was found to be relatively similar. And the mean change in visual acuity, again, was between 1 and 2 letters for each of the four groups, not statistically significant between each of them. And similarly, once again, the proportion of patients who maintained vision at week 96 went from approximately 80% to 76%. 10-letter gain remained stable at about 1/2 of the patients, and greater than 15-letter gain in approximately 1/3 of patients, which is again promising for patients who have visual loss from acute wet macular degeneration. The mean change in central retinal thickening over 96 also had very rapid results within the first 1 or 2 months, and then maintenance of therapy out to 96 weeks. Similarly, the proportion of patients without fluid on OCT also shows that this is maintained, but you can see that the proportion of patients, although visual acuity is maintained, you can see that the OCT is beginning to slip. The percentage of patients who have maintained that at 96 weeks is less than that at 1 year, and whether this is disease progression or tachyphylaxis from this drug is not yet known. So the treatment experience at 2 years demonstrates that 12 weeks since previous injection, new or persistent fluid on OCT, increase of greater than 100 microns compared to the lowest previous score, a loss of 5 letters from the best score in conjunction with recurrent fluid on OCT, new choroidal neovascularization, persistent leak on fluorescein angiography, and new macular hemorrhages were all the criteria for retreatment. The dosing schedule is here, and these are all difficult to look at, but in a prescribed fashion by the treatment guidelines set forth under the indications for Aflibercept were looked at here, and you see patient 2 predominantly at Q8 dosing intervals was to look at whether the longer interval was equally efficacious. So the total number of active injections through week 96 looked like this, with ranibizumab Q4 weeks, Aflibercept 2 milligrams Q4 weeks, and Aflibercept 0.5 milligrams Q4 weeks, and at 2 Q8 weeks, all look like this, with the number of mean injections being slightly less, but not statistically significant at the slightly higher dose. So the mean number of injections for each of the groups did not appear to change, and there was a tendency, as we saw for the recurrent fluid on OCT, the proportion of patients maintaining fluid needed their increased dosing as we went to the 3rd and 4th quartile. So the overall number of injections, fewer injections to the left side of the screen and more frequent injections on the right side of the screen, looks like this. And if we look at this longer area without people needing more injections, again, the general distribution is a bit varied, but all is less than approximately 5%. So it means that 95% of patients really did not need multiple injections, and many people were able to do with far less injections. So the time of the first 2-year injection, you can see here at 4 weeks and 8 weeks, it appeared to maintain effect at 1 and 2 months. But by the time you have 3 months of duration, the effect appeared to wear off, and this was statistically significant versus ranibizumab Q4 weeks. In the time between all 2-year injections was very similar at 8 weeks, but at greater than 12 weeks, again, we see that there's decreased percentage. Again, that was highly statistically significant versus ranibizumab given monthly. The safety data remained stable. There was no increased safety signal even at 96 weeks, and the number of subjects with at least one AE was evenly distributed amongst the groups, both for ocular adverse events as well as ATPC thromboembolic events. So in summary, VIEW 1 and the international VIEW 2 studies involved more than 2,400 treatment-naive patients with wet AMD. So neovascular AMD is the topic of this symposium, and these provide us the strongest data for us to tailor our treatment going forward. However, we know that we don't exist in a perfect world, and the patients are not necessarily treatment naive, and those will be the focus of our discussions. Both studies were similar in safety and efficacy in the treatment of AMD, and intravitreal aflibercept injection was non-inferior to monthly ranibizumab injections. Patients receiving 2 milligrams Q4 months or 2 milligrams Q8 months required fewer injections. So this is the label, that its recommended dose is 2 milligrams administered by intravitreal injection monthly for the first 3 months, followed by 2 milligrams every 8 weeks, Q2 months, and that's the label in the United States for aflibercept for wet AMD. Although it may be dosed as frequently as 2 milligrams every 4 weeks, additional efficacy was not shown, so that's the reason. There's still some unanswered questions. The top pair of OCTs who have received more than 50 injections to maintain the retina and vision, we stopped it and the fluid immediately came back. So what do we do about those patients? That's a difficult question, not answered in study. What do we do with patients who have this serous PED and subretinal fluid? What do we do with PCV? What do we do with other CNV? So those are all questions that are going to be answered or investigated, and I look forward to hearing your questions from the audience. I'm Dr. Subra Wong. Thank you very much for your attention.
Thank you very much, Dr. Wong, for highlighting the dosage schedule in the View 1, View 2, and giving encouraging indication that fewer injections are needed. It's a relatively new kid on the block for us in India, Aflibercept, and most of the indication in our country, as you will see in the subsequent presentations, has been directed more towards PCV. I'd like now to request Dr. Palimat Prasad, who did his MS from PGI here, Chandigarh, then was a senior resident in RP Center, moved on to UK to become a consultant in Warrington. Since 1995, he's been a consultant there, and is also in clinical practice in Leeds. Request him to speak on his current role of Aflibercept in my medical retinal practice.
Thank you very much, and thanks to the AIOC for inviting me and giving this lecture, and that has been put on for today in this session. So what I'm going to go through in the next maybe about 10, 11 minutes is just what the role of Aflibercept, and I keep using EYLEA because that's the drug we use, and how it's changed our practice over the years. So we begin with, firstly, I have no proprietary interest, although we have had training sessions supported by both Bayer and Novartis. So just a quick real-life scenario. Because here, as practitioners, this thing doesn't work as usual. Oh, there we are. Yeah. So there we are. Real-life experience is down here. And before I start doing any injections or any kind of drug here, it has to go through the whole series here. We've got research going there. It's all evidence-based medicine. But then international or national agencies have to give it a license. You all know about off-license and off-label, which means using other indications. But I like this term called off-label. Now, off-label is a nice term because what that means is, to give you a classic example, we used to use Avastin for AMD, neovascular AMD, long time ago, because there was nothing else available. As soon as Lucentis came along, we had a licensed drug available and to be used. So at that stage, if we had used Avastin, that can become an issue because that becomes off-label. So despite informed consent, we're in what we call a sticky wicket. After that, we come down to recommendation because all this comes at a cost. So in the UK, we have what is known as NICE, or NICE, that is the National Institute for Clinical Excellence. So they have to look at cost effectiveness. How effective is it? And is it what is known as QALY, that is quality of every year gained. And depending on they have a mark, and if it's only below that mark, then we can use it in the NHS. Above the mark, we are not. They make the recommendation, and then they pass it on to our what we call the local funding agencies. So we have to get money from what is known as clinical commissioning groups, and they will then decide whether to implement it or not. So you see, it's a long and laborious process, but it helps because it has some sort of regulation. So against that background, I'll be talking a few cases and going through that. So the first one, as I said, was neovascular AMD. We've already seen the VIEW studies. And we got it in November 2013. And the advantage was there were less number of follow-ups. You had a fixed dose regime. And unlike the PRN process or PRN regime for Lucentis, we could decrease the number of visits. We do have a shortage of human resources because we have fixed number of appointees, both trainees and allied health professionals. So we have to be very cautious of the number of visits they come to. In that first year when we introduced, we didn't have any specific criteria of who goes for EYLEA, who goes for Lucentis. We did talk to the patients about all these, and the choice was given to the patient. After 12 months, so here's the classic patient, giant RPED, and we've got the serous, and they've got the fluid and all that. Responds quite well to EYLEA. And a good one, as expected, giant RPEDs do have a rip, so they do get a rip, but no effect, not necessarily any effect on vision. Patient does extremely well. Apologies for that, but patients know I'm presenting the data here. So it does well. Excellent. So remember, this is a protocol. We all heard about it. 3 monthly, then 5, 7, 9, and so on. So in between, you don't have to see these patients. So first year, all patients are signed up to 7 injections. What about our visual gains when we compared that with our 12-month for treatment-naive patients initiated on Lucentis? Equally efficacious. So real world is not too bad after all. 95% are stable. When we look back at the number of injections these patients had, remember what I said about licensing and nice recommendations? So if I start the patient on EYLEA, it has to go through the whole process. So in the first year, they go through 7. So all of them will have 7 and maybe a little more as you go to year 2. But only about a third of these guys in the Lucentis needed as many injections. Remember, it's a PRN protocol or pronto. So that means there's about a 20%, and this we had known from many, many years, there's about a 20% of patients treated with Lucentis will not need more than 3 injections. So that set us thinking, are we tending to overtreat some of these patients? So what the other concern, frank concern, was when we started doing the EYLEA, we found that some of these patients will appear to have lost vision temporarily. So just a little bit worried. So here's a patient treated with EYLEA, and nice, quite a boggy one, and dries up nicely. But you can see it dries up so nicely, but it's almost as if the retina becomes thinned out. So a little bit of worry there. And so based on that, what we said is, look, we'll continue with EYLEA as a first line, but there are certain patients who we just treat with Lucentis, and that's, as I said, it's my current role, current practice. So early small classic CNVM, they do extremely well with 3 injections. That's, as I said, about maybe 10-15% of our patients. There's also another group, because it's an aging population in the UK, and we have patients who come in and the family are not too keen on going to 7 injections, and they may be in advanced stage, so we're not very sure. So we have to demonstrate whether it's going to work or not. There are patients with dementia, for example, so it could be quite tricky to subject them to so many injections. So we use those as well, with good old Lucentis and that. Having decided that, knowing that EYLEA works very well, we start to switch patients along, and this you can find in the literature anyway. And generally speaking, if they've had more than 7 Lucentis in the last 12 months, or if they needed more than Q8, because remember, after the loading phase, EYLEA, you need to do only Q8. So you might as well go for EYLEA. So that was about neovascular AMD. Once we got our experience with that, then, of course, we started getting approval for diabetic retinopathy. We got all these studies. Works very well and good visual gain. Here's a gentleman, about 82, I think. Comes in quite late, very boggy, full of edema there. Right eye, left eye, and lo and behold, after 5 injections, dries out beautifully. So it works exceedingly well. I'm sorry it didn't show up fully, but just a quick thing about our treatment protocol. So 5 injections, assess in month 6, stable disease, go down every 2 months, and then after 12 months, treat and extend. If they do not respond, then we go down this way, and if it's phakic, dexamethasone, if it's aphakic, ILUVIEN. Just another example. Youngish chap has this macular edema, treats beautifully, but again, look at this thing. I mean, I'm still waiting for somebody to show up whether this is significant at all, because it does. I'll show you all these slides. I don't know whether it's a rapid detergence which does it. What about non-responders or switch from other patients or on other drugs? Very similar, that if they don't respond, we go to the start almost as if the loading phase of 5 and down this route. If it doesn't work, then we go to the steroids. As I said, in the UK, it's dexamethasone if it's phakic, and ILUVIEN if it's only pseudophakic. Works well. Switch patients. Here's a gentleman, elderly gentleman, and he cycles to the clinic. And he has got a bit of cataract, although the view is not very good, but he's functioning quite well. But the poor man needs, I think he must have had about 17 or 18 injections of things like Avastin and then Lucentis and all sorts of things. But despite that, and that's a nice feature of, I mean, a good feature of diabetic macular edema, that even the yo-yoing, if you manage to dry it out, it still preserves vision. So he's done well, and decreased frequency. Cataract surgery in patients with DMO, again, I use it because it's got a long interval. I use it preoperatively and does well. Then we come to another little group of conditions where we have not licenses yet for these sort of things. Now, here's a patient who's had traction in treated PDR, traction diabetic retinopathy, does well after just PRP, that is, but then has a vitreous hemorrhage. So the only thing we use is Avastin because none of the others are actually licensed, so it was off-label. Unfortunately, he comes back a few days later, symptomatic because the traction has started to extend towards the macula. Fortunately, does well with vitrectomy and further laser, but that's not me thinking that I think Avastin sometimes can be too aggressive. So here's an example of a 15-year-old girl, recently diagnosed diabetic, but suddenly worsens. Look at the eye, and looks really nasty. I don't want to laser her because we don't want, she's only 15, she's going to start driving soon, don't want to lose the fields, and maybe just a metabolic control. So in these patients, again, one single dose of EYLEA, off-label, mind you, but does well. This is about 12 to 18 months, and this girl still comes, and she's gone back to uni and is pursuing her education. So it does well. Similarly, another example, rapid VEGF build-up, 39-year-old lady with preeclampsia, right eye looks horrible. If you think that's horrible, look at the left eye. And we have seen her 4 or 5 months before that, no evidence of any NVE or NVD, but for some reason this has become hot. I can't do it, obviously we don't want to laser because it's just one-off. 2, no anti-VEGF because she's pregnant. 3, she can't, it's too premature to deliver, so we just hang in there, pray, starts to bleed. But quickly, as soon as she reached 30 weeks, discuss with the obstetrician, does a C-section, and then quick eye shoot the EYLEA right eye, does beautifully well, and the VR surgeon does an excellent job, vision from hand movements to 6/12. So these are sort of things, I would like to call it as an EYLEA light sort of thing. CRVOs is great, I like that, because again, the big thing here is that it's good for even non-perfused eyes, so it takes away that little bit of worry. So it does exceedingly well. All CRVOs are in it, 100%. Again, this little bit of thinning, persistent thinning. No answer for that. BRVO Vibrant study shows that it's good, but in my practice, I find, again, frankly, Lucentis equally well, sometimes with laser as well. So I'm not, I don't switch them. Again, here's the BRVO, and again, that sort of very atrophic-looking retina. Other things, we come to the miscellaneous group. The Mayor showed, this is pre and post, myopic CNV, does well, maybe on just a couple of injections, does great. This is the planet. So there's somebody who's been treated, because we have pool lists, somebody's been treated as wet AMD, neovascular AMD, and then not responding to Lucentis. Of course, then we give the ICG, and this guy, she's got a polyp, and so she goes and has combi therapy with PDT and EYLEA. Of course, now the planet shows that even monotherapy is good enough for EYLEA. It works well as a monotherapy, other than, of course, I'm sure we are going to listen to more talks today, other than rate of recurrence if you just do monotherapy. So maybe combi therapy is good. We have CSR patients who had PDT breakthrough. These are things we used to use Avastin as a completely unlicensed drug, but now we've got a licensed drug. Again, it's off-label, but I'm on safer grounds. So it does well. So in summary, all neovascular AMDs, other than small classic CNVMs and eyes with poor prognosis. Diabetic retinopathy, all DMOs. PRN for eyes with high VEGF, as I said, I call it Avastin light, per operative. And of course, with the DRCR protocol T, we now know that you don't have to go to that 5 injections, loading, et cetera, et cetera. It works equally well with PRN. And also that subgroup, there's a subgroup of DMO patients who do much better with Aflibercept versus Avastin, and that is the ones with vision of less than 69 letters, which is about 20/50. CRVOs, I love it. BRVOs, open house there. And miscellaneous conditions, as I said, off-label. Thank you very much.
Thank you, Dr. Prasad. We'll have a discussion on these other conditions later. I'd like to introduce Dr. Naresh Yadav, who will talk on the experience of Narayana Nethralaya, a very respected institution in our country. And Dr. Naresh Yadav is the head of the retina service there. And I like to call him the quiet giant. He's a very gifted surgeon and an excellent specialist.
Thanks, sir. Very good afternoon to one and all. I'll be speaking on the Aflibercept Narayana Nethralaya experience. So, as we all know, Aflibercept is a recombinant fusion protein which binds to the circulating VEGFs and acts like a VEGF trap. And it inhibits the activity of VEGF-A, VEGF-B, as well as the placental growth factor. So this is our experience. So we have used around in 47 eye, number of total injections 55, and the most of the injections were done for CNVM, then followed by PCV, RVO, and diabetic retinopathy. So, but a lot of our patients, we are not able to give the dosing as per the protocol, because after one injection, if the patient shows response because of the cost issues, sometimes the patient switch over to the other anti-VEGFs. So it's really difficult. Only PCV cases we have decent number who have taken the loading dose or more than 3 injections. But other indications, most of them, they just take one and then we have to switch over or vice versa. So these are the demographics. So PCVA, we gave it in 7 cases. 7 eyes received EYLEA. The corrected distance visual acuity improved. This is at 1 month, because most of the patients don't have the follow-up also, and after one injection they could have switched over. So I've just taken a uniform 1 month. The distance visual acuity improved from 0.78 to 0.72. Similarly, the amount of subretinal fluid decreased from 174 microns to 169. Same way, the pigment epithelial detachment decreased from 629 to 562. And now I'll show you a few cases. This is a 67-year-old male, decreased vision in both the eyes since 3 weeks. The right eye vision was 618, left eye was 636, no systemic complaints, no history of steroid intake. And this is the multicolor of the right eye. If you see here, there's a small subretinal nodule here, some subretinal hemorrhage, and there is a subretinal detachment here that was involving the macular area. So this is the FA-ICG. You can see a very typical CSR-like leak here and a cluster of polyps here. So this is a spectrum of the pachychoroid. You can see CSR, PCV at the same time. And recently we're seeing a lot of patients where CSR patients can develop PCVA after some time. So this is the corresponding OCT. You can see the subretinal fluid, PED, and this could be the place that is harboring the polyp. And this is at the foveal area. There was a large amount of subretinal fluid. So and this is the left eye. There was a solitary polyp here with a hemorrhagic PED. And the patient underwent, we did focal at this leak, and we gave 2 EYLEAs, and at 3 months you can see the focal leak, CSR has gone. The polyps also have regressed with good improvement. The patient had 6.6 at around 6 months. Similarly, the left eye also responded well. We did a focal laser here along with the EYLEA, and this patient also improved very well. This is another case, 63-year-old male, presented with sudden diminution of vision since 1 week. The vision in the right eye was 3 meters, left eye was normal. And I don't have the fundus photo, but you can see this is the FFA, and you see a PED here, and the star shows the polyps. There's one solitary polyp here, and a cluster of polyps with BVN also was evident. And this is the corresponding OCT with the PEDs and subretinal fluid. And this patient, we gave 3 Avastin, showed good improvement, and then there was a recurrence at 18 months. So you can see there's a new lesions here. And at this point of time, we thought of giving EYLEA, and the patient improved quite well. The polyps have regressed. We could repeat the ICG. The polyps have regressed, but some faint BVN still persists. So this is another case 3. You can see there's a massive subretinal hemorrhage here. 75-year-old female, hypertensive. The vision was 3 meters. And this patient also received, we had to pneumatically displace the subretinal blood. And there was a good improvement with EYLEA injection. So then we have used it in 21 eyes with CNVM. The corrected distance visual acuity improved from 0.38 to 0.33. Similarly, the amount of subretinal fluid decreased from 70 to 30, and PED 240 from 150. This is the 75-year-old male, classic CNVM. And this is the late frame. And the patient underwent 2 injections of EYLEA. This is the OCT. So we have the OCT angio also. We could do that. So the superficial retinal vasculature looks okay. And you can appreciate some changes at the deep retina and at the choroid capillary. And we manually segmented. So you can see that after injection, there's a good improvement. The morphology and the architecture has come down, so there was good response with the EYLEA injection. This is another case, 85-year-old male, complained of decreased vision since 1 week. The left eye already had a disciform scar. The right eye vision was 612. So these are the OCT images. You can see intraretinal edema, some subretinal fluid here, and this could be the site of the membrane. And from November 2012 to August 2016, he received 11 injections of Lucentis with a waxing and waning course. So these are the various OCTs. And then he received EYLEA, and with just 1 injection, the patient stabilized. And we have used it in diabetic retinopathy also. And the central foveal thickness reduced from 580 to 540 at 1 month, and the visual acuity improved from 0.42 to 0.38. And this is one illustrative case. The patient, you can see the OCT images, 68-year-old male, diabetic since 20 years, hypertensive, well controlled, and the vision was 618, 624. You can see the right eye and the left eye gross cystoid changes. And he received Avastin, responded, and after then he stopped responding to Avastin. So at this point, we thought of giving the option of EYLEA. So if you have to switch anti-VEGF, it makes more sense to switch to EYLEA as compared from Lucentis to Avastin or Avastin to Lucentis. And this is, you can see the improvement. After 1 EYLEA, the patient has been stable and vision has stabilized. Same way with the RVO also we have used it in. So the vision improved from 0.45 to 0.3, CFT decreased from 450 to 350. And this is another case, 67-year-old male. You can see the CRVO. There was a gross cystoid macular edema with some amount of subretinal fluid. This patient received Ozurdex, did very well. The OCT almost became totally flat, but at 120 days there was a recurrence. So at this point of time we thought of, he was not willing for EYLEA. We gave 2 Avastin and then stopped responding, and then we tried EYLEA with good improvement. So this is the final. He had 6.9 at around with a good follow-up. So studies have shown that polyp closure rate is better with EYLEA. The PLANET study confirms that. And if need to switch from Avastin Lucentis, makes sense to try EYLEA. Has shown to be effective in patients who have stopped responding to Avastin Lucentis. and reports show that pigment-thread detachments do better with EYLEA. So a lot of, I think, hope is there. We have been using it, but the problem is to continue the patients on EYLEA. There's a lot of switchover that keeps happening in India, but I think that's the real life experience. So I think I'll conclude with that. Thanks.
Thank you, Dr. Naresh. Before we go ahead with the next presentation, let's have a short discussion on wet AMD and role of Aflibercept. In our experience in the Indian scenario, it has been that nowadays as more ICG is being done, especially with SLO-based systems all across the country, we are finding that many of these cases whom we had labeled as AMD are actually have underlying polyps or are part of the pachychoroid spectrum or have branching vascular networks. What would be the experience in UK or in the United States? And I would also like Raja and Manish to give their view on this after you're through.
Want to go with that? Yeah. Thanks for that. Well, what we do is the proportion was, I mean, initially just with FFA we used to say 100%, and then only if it doesn't respond, we go for ICG and all that sort of thing. But now we have a low threshold. But I still think that in the UK, at least in the predominantly white Caucasian population, the polyps are not as much as the others. So that is number one. And I think that's absolutely vital. So the practice is still to treat it in the what I'd call the district general hospitals, okay, not the university hospitals, as this. And very rarely do we come across these sort of non-responsive, and particularly the clinical lesions that we find. And that's when we would just refer on. It's interesting that you talk about the number of polyps in your so-called neovascular wet AMD, because then I think that would make more sense to have EYLEA as an initiating drug in this sort of scenario. Okay.
I have a similar experience. Most of our patients in the United States are Caucasian, and they have more classic age-related macular degeneration features. PCV is actually quite rare in the population that we see. In fact, my ICG use has gone down over the last 5 or 10 years. We keep trying to dust it off or find something to do with it. Cost is a big factor. And we see for other diseases such as vein occlusion, it's the unresolved fact that there's still vascular pathology that keeps the fluid coming back. And what we see is our most difficult problem is these PEDs, because they very often don't respond to any of the drugs, and they are highly elevated, they look terrible, and we don't have much to offer at this point.
I would like Raja to give his point of view as to what percentage he would describe in an institution like his, what they think, and what are the clinical signs which he would initially see in a wet AMD case, which would make him start with Aflibercept instead of ranibizumab.
Yeah, again, great presentations by all the three speakers. I did a retrospective study way back in 2011 of all the so-called AMD patients which came to our institute, looked at their ICGs ultimately, and then out of which we found that about 40% were PCVs. Now that's tertiary practice, so a lot of patients are referred, probably some of them may have been treated earlier. So it could be both ways. So if you have treated earlier, there could be partial regression of polyps which you don't pick up, so that could be an underestimation now. But it could be the other way around also, that the tough ones which don't respond are sent to the referring hospitals. You probably could get a higher percentage of PCV patients because they are non-responders. So it's somewhere around 30 to 40% that I would put the figure at, in terms of PCV. But what exactly you look for in these patients, there are both clinical signs as well as OCT-based signs which can give you a big hint whether you're dealing with PCV. And some of them are, extensive exudation or orangish lesions which are actually polyps. If you do an ICG, that's the exact corresponding area where you see these polyps. So sometimes you can see these orange lesions. The other important thing is the hemorrhagic variety, where if you have a large submacular hemorrhage, these are probably patients where you should suspect PCV. On OCT sign, you have what you call as a notched PED or a thumb-like PED, and you have an elevation, a steep elevation on one side and a slow P elevation on the other side. These are not sharp dome-shaped PEDs. So on one side you have a sharp elevation, on the other side you have a shallow slope. These are the lesions that you look for on an OCT, which you could suspect directly as these are the signs of polyp in these patients. The other thing is that in PCVs you tend to get more SRF than an intraretinal fluid. So these are the if you have the other thing which I have seen very common is PEDs, large PEDs respond well to EYLEA than to eccentrics or Lucentis or Avastin. So if you have a patient with large PED, those are kind of patients where you could directly start off with an EYLEA rather than struggling with other injections and then trying to switch over.
Yeah, I would like Manish to reflect on what would be the number of cases in his practice who would be presenting with a sign of vitreous hemorrhage of so-called in the AMD subgroup.
Well, I think vitreous hemorrhage in an AMD is something that we see very rarely, and I think I might see something like 1 or 2 a month.
I meant it could be underlying PCV.
Oh, yeah. Yeah, sure. So PCV itself, like Raja was commenting that he sees about 30 to 40%. I think we don't see as much, but probably I would put it at about 20%. And most of them have these large serosanguinous collections, and that immediately prompts you to think that this is not just a simple AMD, or you see a large PED, or you see blotches, and then you see very non-continuous hemorrhages. You'll see something on the superior arcade or inferior arcade, and then you'll see another lesion in the foveal area, and you immediately know that this is a different pattern and it's not a connected pattern, and you want to do an FA-ICG on these patients, and then instantly you can diagnose them. And I think I agree that these are the cases which would respond better to EYLEA, along with the focal laser if there's an extrafoveal polyp that you pick up, and that prevents the recurrences as well if you can laser those areas.
Now, what about the cases where the presenting feature is a breakthrough?
Yeah, then those of course you operate. I mean, on the ultrasound you do get an impression that there is a slight elevation in the macular area, so you already suspect it. Or you see some signs in the other eye which makes you suspect. So you go in with an idea, with a prognosis to the patient that maybe the central vision may be hampered, because at times when you clear the hemorrhage you see a large scar as well and blotchy lesions.
Now request Dr. Raja Narayan. He'll speak on clinical evidence, that is the PLANET study, Aflibercept in PCV, and Raja Narayanan is from another well-known apex institution of the country, L.V. Prasad Institute. He heads the retina service there. This is also our dynamic secretary of the Vitreoretinal Society of India.
Till he gets his slides on, Dr. Wang, I wanted to ask you, when do you switch a patient? Like supposing a patient is on Lucentis for wet AMD, when would you decide to switch him to EYLEA? Are there some specific criteria and features which you decide, and when do you switch?
Well, it's a very good question. The easiest ones are the ones that are doing extremely well, and we don't want to switch them. I think the cost considerations are serious. You may have heard we had a recent election, and some of our healthcare is changing quite a bit. So whenever somebody is stable and they're doing well, and they can switch for cost considerations, I want to give them a trial of moving to Avastin because we have at least some thought that maintenance may be reasonable. However, with a futility criteria in terms of active leakage for wet AMD, usually I go fairly quickly. If there is no response, less than 10% change after 3 injections, I switch. I very frequently go to EYLEA, particularly for the vascular diseases, but from Lucentis, I switch to EYLEA. Sometimes I have EYLEA as a primary drug.
Thank you, Dr. Huang.
Thank you.
Request Raja to.
Once again, a very good afternoon. I head the Clinical Research Department, LV Prasad Institute, just a small correction. I'll be talking on Aflibercept in PCV, clinical trials and evidence. And my presentation will be quite brief because presenting clinical trials can become very boring at times. I'll be concentrating more on the top line results and the main results which we have. So PCV is a subtype of neovascular AMD, and as we have discussed, a lot of our AMD patients turn out to be PCV, and we have also discussed what features we should look for in these patients just in the brief discussion that we had earlier. Just to give a perspective of the overall prevalence of PCV in the Asian community, it's anywhere around 25 to 50% is the overall figure that we see in most of the publications. And in the Caucasian patients, it's generally less, about 10%. But in those who are non-responders, which you see at the very end, there it comes to about 20% patients who have probably PCV. And anti-VEGF has a very important role in PCV management, not just by the results that we get in these patients, but also if you look at the VEGF concentration in these patients in the aqueous humor, AMD and PCV, also patients have high levels of VEGF. So we all are aware of combination treatment of anti-VEGF and photodynamic therapy in PCV, whereas in AMD it's not the standard of care to do PDT in these patients. But it's all started off with the Everest trial, the Everest 1 trial. The Everest 2 results were recently presented. But what you look at in this slide is the Everest 1 trial, they had only the 6-month data, which was very well known and published. But if you look at the Everest 2 trial, you can see that the gain in vision in the combination arm, the blue bar is the combination treatment. They had slightly better visual acuity gain compared to the monotherapy ranibizumab. And also if you see the polyp regression, this is where the big difference comes in terms of the future slides which I will be showing, that the polyp regression rate was close to 70% in the combination treatment, whereas it was just about 35% in the monotherapy ranibizumab group. And because of this, it has been commonly performed, PDT has been commonly performed as a combination treatment in most part of the world, but in India, PDT has not been very accessible, both in terms of the financial accessibility as well as the infrastructure. So there are a few limitations. In terms of efficacy and safety, I think PDT has to be repeated, although much less than anti-VEGF. So it has a slight advantage that PDT does not have to be repeated as often as anti-VEGF. But in terms of practicality, I think the number of actively working condition PDT machines in India at this point of time may be less than 10. So and those which are working right now have not been serviced for a long time because Zeiss laser machines have not been serviced by their engineers. They stopped doing that. So the kind of laser energy output which is coming out at this time is also not very clear. And then you have the issue of patients having to protect themselves from bright light or even actively going out in sunlight daytime. It's a big problem for patients because a lot of our patients travel from far away and come to other cities for treatment. And then the cost is a definite issue because although Lucentis started off with a retail price of 70,000 rupees or so, right now Eccentrix has come down to about 18,000 rupees. But PDT has not changed significantly. It's quite high and it's out of reach for most of the population. So with these concerns, let us look at the results of Aflibercept monotherapy for the treatment of PCV. Now, just to start off, the VIEW trials, VIEW 1 and VIEW 2 were done without any PDT combination, but it was for AMD. But in the Japanese patients, they also did the subgroup analysis where they looked at patients out of the View 2 study who had PCV. And what they found was the PCV and non-PCV patients had similar results in terms of visual improvement and OCT retinal thickness reduction. So then we have now many more publications on PCV polyp regression, specifically comparative therapy. So what in the VALT study, what they looked at was the primary outcome was the patients who had less than 15 letters of visual loss. So what they found was that most of the patients maintained their vision. 90% of the patients maintained their vision, and in fact there was a mean gain of 9 letters in these patients. And also about 60% of patients had polyp regression or complete polyp regression. So this is what is surprising with Aflibercept treatment, that the percentage of patients who have complete polyp regression is probably much more than what has been shown by way of Everest trial or many other trials with Lucentis or ranibizumab in PCV. So what you see here is that at month 3 itself, a lot of these patients show complete regression of polyps, more than 60%, and by month 12, more than 65% of patients have complete regression of polyps. So the rationale could be from this trial is that if a patient, if you give 3 loading doses of Aflibercept, and at month 3 if you repeat an ICG and you see that the patient still has active polyps, you may offer a photodynamic therapy treatment, but it may not be required for most of the patients to do PDT at the initial baseline. So the PLANET study is the pivotal study based on which we'll have further discussions, and it was a multi-center trial, phase 3, phase 4 trial, and the primary objective was to determine whether Aflibercept monotherapy was non-inferior to combination of monotherapy and PDT, and the secondary objective was to look at the patients who the rescue treatment of PDT and regression of polyps. So the baseline characteristics were pretty much similar in both the arms, and the gain of 5, 10 or 15 letters was similar in both the arms, and the number of patients who gained more than 15 letters was about 33 to 35%. And over 85% of patients did not require a rescue photodynamic therapy in year 1. So what it shows is that about only 15% of patients required PDT in this study. And this is a very important result because, as I had mentioned, that PDT kind of, both in terms of financial cost and also the practicality, has its own limitations, unique limitations. So Aflibercept treatment could be a way out to reduce the number of PDT rescue treatments. And over 80% of patients showed no active polyps at week 52. So this is again an amazing result. What we need to do is probably replicate, if more trials, we need to replicate this kind of result, because if 80% of patients have complete regression of polyps, whereas in Everest 2 it showed about 75% or so. So that's something which has a huge impact on the management of our patients. But again, here I believe that there is a difference in terms of what their definition is. You cannot exactly compare Everest versus PLANET trial, because here what they have looked at is active polyps, and whether this means complete regression of polyps, what is the meaning of inactive and active polyp. So that is something which has to come out through the publication. It has not yet been published, but yes, the polyps are inactive in quite a significant percentage of patients after Aflibercept treatment. The only thing is the mean number of injections was 8 in this study, and in Everest 2 data, what they have shown is that in the combination treatment, the mean number of injections was about 6. So there is a difference of about 2 injections between this PLANET trial and Everest. Again, it's not a comparative trial. You just cannot compare Everest and PLANET study just because they were not a head-to-head trial, but these are the trends that we have. The adverse events were quite similar in profile. The second year Planet is continuing. The results are expected in July this year. What they're trying to do is in the second year they're using the treat and extend regimen rather than a fixed protocol of monthly injections. So let us see how the results shape up after the treat and extend regimen in year 2. So in summary, the Planet study has shown that Aflibercept monotherapy has favorable visual gains and high rates of polyp inactivation, and also a lot of patients gain more than 15 letters or even 10 letters. Over 85% of patients did not require rescue PDT treatment, which is a very important information for our patients, and also that the second year of Planet is looking at treat and extend regimen. So thank you very much for your kind attention. And I invite you for the next midterm and annual VRSI meetings in Palampur and Puri.
Thanks, Dr. Raja. It was a very crisp presentation on PCV. Next, I'd like to invite my close friend, Dr. Shobhit Chawla, who's the Vice President of the VRSI Society of India, that is the Vitreoretinal Society, which is a very vibrant society with a very large number of people in it. And he's the Managing Director of Prakash Netra Kendra at Lucknow in the center of India. So over to you, Dr. Shobhit, who will be speaking on Aflibercept in PCV, the case presentation series.
I'll be just presenting some real-world cases where we have used Aflibercept with some encouraging results. Our first case is a 69-year-old male, diminution of vision right eye for 6 months. He presented in 2013 and visual acuity was 6/36. Only an OCT was done at that time and a fluorescein angiography. He was not subjected to an ICG at that time. Probable diagnosis was based on the OCT and from our experience, because at that time the dye was not available in the country for a period of nearly 4 months. So he was treated. Later on, when it was proven to be PCV, we did a ICG later. PDT was done. Patient did not improve. Visual acuity right eye was 6/36. After 1 month, there was no Aflibercept available at that time in the country. After 1 month, 2 injections of bevacizumab were given at an interval of 1 month, followed by 1 injection of ranibizumab. When he was not, vision still did not improve, neither the OCT picture much. Then we had the new injection with us, the EYLEA, and he was given 2 injections of Aflibercept, interval of 2 months because of some logistics issues. He could not make it after 1 month. Vision improved to 6/18. OCT picture also showed restoration of normal anatomy at the posterior pole. Our second case presented with this kind of with 82-year-old male, diminution of vision right eye since 15 days. Visual acuity was 6/9. We were not that attuned to, recognizing PCV, early PCV with this kind of features, which we would highly suspect now if we had an OCT picture like this. At this stage, only an FA was done and a probable diagnosis of occult CNVM. Patient was treated on ranibizumab. He responded. Patient presented after 1 year of treatment. He had the 4 loading injection, 3 loading and 1 PRN basis injection meanwhile. The first year, then he presented with this deterioration. Vision was 6/36. At this stage, ICG was done and a polyp was detected here. Simultaneously, ICG and FFA was done. A diagnosis of PCV was established. Injection of Aflibercept was given. 2 injections again at an interval of 2 months because the case had to be, the Aflibercept had to be procured through his department. Vision improved to 6/9 and normal anatomy was restored. So another case, recurrence after 4, this is the same case actually, and I'm just showing another cut of the same. Another case, 63-year-old female, diminution of vision 15 days, 6/36, probable diagnosis at this stage was CNVM, and this track was somehow missed at that time. Otherwise, it could have been labeled more of a pachychoroid converting to PCV. PDT left eye was done nonetheless. Looking at the picture, patient herself opted for PDT, followed by 5 injections of ranibizumab at interval of 1 month. Vision did not improve. Patient was lost to follow-up, presented after a gap of 1 year. Again, with a diminution to 1 meter counting finger, and a diagnosis of PCV was made on the basis of this OCT and the presence of pachyvessels on and branching vascular networks on ICG. Patient was treated. This was the other eye of the patient. Patient was treated with Aflibercept, 3 injections at interval of 1 month. 6/18 visual acuity has been achieved in this case. Another use, this patient presented with, gave previous history. In fact, he was treated at our center with ranibizumab for CNVM, presented with vitreous hemorrhage. Patient was outstation, lived in Delhi, came back to us, and looking at his history, we went ahead, did a vitrectomy. Right eye was controlled post-vitrectomy with ICG, we detected this kind of a picture. We made a diagnosis of PCV and because of the large chorioretinal atrophy, and he was stabilized with subsequent Aflibercept therapy following his vitrectomy. Another case, massive vitreous hemorrhage. I'll just show you submacular hemorrhage, post-vitrectomy and subretinal TVA, lavage and intravitreal anti-VEGF. It was his only eye. We achieved a 660 visual acuity. We don't have a pre-op picture, so we show you the video. We did a vitrectomy, and it was a massive hemorrhage. Subretinal TPA was done after vitrectomy, and fluid gas exchange. Patient had dispersed hemorrhage on 2 occasions as the submacular blood leaked into the vitreous after that, and finally patient had to have about 2 vitreous lavages and stabilized at 660 visual acuity. We have now followed up the patient with 1 injection of Aflibercept, and he's maintaining vision. Another case presented with vitreous hemorrhage. This is post-vitrectomy image in ICG, more like a peripheral hemorrhagic choroidovasculopathy, and the ICG showed this large, nice group of polyps. Again treated with focal laser, Aflibercept, 1 given immediate post-vitrectomy, 1 month later. Still in follow-up and doing quite well. Good visual acuity has been achieved as the macula was not affected, 6/12 visual acuity. Thank you very much. I would like to now pose my first question to initiate the discussion. I'd like to pose it to Dr. Naresh Yadav and to Ajay Durrani. What would be if you are treating a case of PCV and you have polyps there amenable to laser photocoagulation, what would be the timing of your photocoagulation vis-a-vis intravitreal therapy?
I think that will depend upon the amount of exudation. If the exudation is not much, you feel that laser is possible, then definitely laser can be done. But if there is a lot of subretinal exudation, lot of subretinal hemorrhage, then you can give intravitreal injection, and then again after 2 weeks, 3 weeks, you could take a call and do the focal laser.
Any difference of opinion, Ajay?
Yeah, I usually, if there's a lot of fluid on OCT where the polyps are there, then I would wait for it to dry. If I'm doing Aflibercept, I can easily have, a 2-month window. So I would wait till at least 1 month, see the OCT. If the area is dry, then I would be very happy to do a focal laser there because I'll use less energy in that patient.
Any opinion from any of the other panelists on the same?
I do try to laser at the first instance. Most of the time it does manifest even you just use a slightly higher power, as long as it's an extrafoveal polyp seen. And a lot of times if you note the site of the polyp, if it's a big polyp, then the hemorrhage from that area is a little bit, that area looks a little whitish and is got more elevation, so the hemorrhage is besides it and not exactly bang on. So it actually makes it easy for us to identify that, comparing it with the ICG and do it as well.
The case that I showed, most of the time the hemorrhage, the polyps are at the edge of the hemorrhagic PED. So many times, if that is the situation, you can definitely do it at the same time. If there is a fluid there and hemorrhage there, then I think you could wait for some time after giving injection.
Yeah,
but most of the time, I agree, it is possible.
Yeah, I agree with Manish because these are extrafoveal where we are doing thermal laser, and the amount of edema and exudation usually tends to be more at the fovea. And so even if it's not that, exudation is a little bit there, you can still go with the higher power in these peripheral polyps.
I wanted to ask a question for the PCV experts. When you're following these lesions, are you following the OCT for regression of fluid, or are you looking at the ICG for actual closure of the polyp?
Yeah, that's a very good question, a very important question. I can give you both answers, what the trials did and what we do practically. The trials do an ICG every 3 months, that is every week 12, and then if there is an active polyp, then they are randomized again to, in the trials they offered PDT again. But in our situation, what we do is usually it's about 4 to 6 months that we repeat the ICG. But if there is any fluid on OCT, you must inject with an anti-VEGF. But the repeat PDT in practical life, in real life, is usually about 4 to 6 months. That's when we start looking at offering a repeat PDT. So there's a slight difference in the trials versus real life.
Well, the PLANET study in my clinical practice has made a difference. I like to repeat an ICG if possible after the 3rd month, and I don't like to repeat a PDT. I like to continue with Aflibercept, especially if I have a good visual acuity patient. I'm very cautious of doing PDT in these patients. Many of these are only-eyed patients. They've already lost one eye as part of the disease by the time they have come in for treatment, it's a precious eye.
I usually do the ICG at the beginning to diagnose, but not necessarily repeat it as long as the clinical condition looks to be resolving, and then we just take it PRN basis. If I feel that there's a recurrence, then I would repeat it. But now we are using a new tool, the angio-OCT, to document these cases at the beginning itself. And it's very early. We've just been using it for the last 4-5 months and are still learning. But in some of these IPCVs, we have been able to exactly the site of the polyp, and on the angio-OCT you do see a lesion corresponding to that, and we have seen that it kind of goes away once you've started the treatment process. So that's another tool now that we've just started using apart from ICG.
Yeah, we've also recently just gone on to, and the correlation between ICG and the OCT angio is encouraging. Though technically it is a little difficult to place the box at exactly the same location. More than that, it's at times a little difficult to get a very good OCTA because of the focusing. So we are using the SLO-based Heidelberg system, and we are finding that if you get a precise focus, you're able to get very good OCT images, angio images.
Is there any difference in how you pick up the polyp or the BVN? BVN is better picked up, or the branching vascular network is better picked up than the polyps, or both are equally?
Yeah,
my experience is just now limited, and for BVN, I have relied more on ICG.
Can I take that question? So we have looked at, in our experience, also there's a publication from Japan, I guess, where they have compared the sensitivity and specificity of OCT angio versus ICG in PCV. And what they have seen, and we have also seen, is the BVN is picked up on OCT angiography. It's a very sensitive tool, probably better than ICG, but the polyp is better picked up on ICG. But the problem with OCT angiography is that it is prone to artifacts. If there is a large PD or a hemorrhage or any elevation, you can miss including a BVN, or portions of BVN. So you may miss polyps if you rely only on OCT angiography. But BVN is very nicely picked up on OCT angiography.
But to pick that up, you need an ICG. If you don't have ICG, if you just rely on OCT angio, then getting the right area is difficult.
I think for diagnosis and for establishing the exact correlation, I think need an ICG angiography, and then you correlate what you see. You see the network of the vessels with the surrounding halo like you would see for any other active subretinal membrane kind of a thing. And you may see a polyp in some of these cases, or a polypoid resembling structure corresponding to what you saw on the ICG. But I don't think without doing ICG, if you just do a OCT angio, you can't say that this is IPCV. I don't think we can.
I just have, since both I can see Bayer and Novartis people sitting here, there's still a message for, they're aware of it probably, that, the cost is still an important factor. While I presented the PLANET trial, the differences were that, in PLANET, the PDT was a delayed option, whereas in Everest, baseline patients were offered PDT. But if you look at the number of injections, 8 injections versus 6 injections of EYLEA versus eccentrics, it's still cost effective to do eccentrics multiple injections rather than multiple injections of EYLEA at this time in our country. So the cost is an important factor. While clinical science is guiding our results, we are unable to offer the treatment, or the patients are unable to accept the treatment which we are trying to offer.
Sorry, just a question to you guys who've been treating a lot of these. I've showed pictures of post-PDT, CSR coming with secondary CNVMs. So in your group of PCV guys, have you seen this happen at all?
Yeah, chronic CSCR. We have a lot of these cases.
The PCV group.
Yeah, PCV group. A lot of these cases are chronic CSCR, especially the younger patients who've converted to PCV. You're able to see pachychoroid, the typical pachychoroid spectrum, that kind of dilated vessels, thinning of the satellars, and then you see. So they may not show frank polyps initially, but down the line they will get polyps.
I just wanted to know that, do you have any thought, all these panelists, that why are we seeing this disease in the Southeast Asian, Chinese and Japanese population? Is it a genetic different disease, or is it due to the, no. I don't know whether it's a...
There's a recent study from, I'm not sure, Norway or Sweden, where they have done routine ICG for patients with AMD, and they found that around 35% of the patients had PCVA. I think in the US and a lot of places, they're not really routinely doing the ICG. So there could be underreportage.
Just to comment on that, because in Liverpool, we are close to Liverpool, where the University Hospital is, so they reviewed about 8-9 years ago, they reviewed all the images, the floor scene and everything, and then they went back and they said, there is a proportion of patients with PCV, and it was all hullabulla. And they said it's all ICG for everybody. But strangely, after 10 years down the line, that hasn't impacted on the sort of clinical practice. So you know what I mean? So there is something there, but the behavior doesn't seem to be as aggressive as these people. So I don't know what it is. There must be some sort of racial difference.
And in our practice, maybe it's a referral center, so we get about 5 to 8% patient presenting with vitreous hemorrhage of the PC group as the presenting feature. And I would just like to ask the panel and everybody, what about RP rips? How often have they seen them happening with PCV patients during the treatment? Because here we are dealing with large tense PEDs at times.
I have not seen that many patients. I would probably put it at about less than 2% of patients. Even 2% is high probably. But
same in my experience also. Only one patient over 5 years.
Yeah, and even in the trial where they used the high-dose ranibizumab for AMD, the 2 milligram, even in that they had less than 5% incidence of RP rip.
No, maybe the RP is more healthier in these PCV patients rather than the AMD subgroup, Yeah, but it's where the RP is basically diseased in AMD.
Yeah, I agree with that because there is this, just because I've shown you pictures, giant RPD, serous ones with the classic AMD, rips are not uncommon at all now.
No, but if you talk of rips, I've seen the rips happening in the odd situation with like thermotherapy, micropulse. Anything you do to these patients once in a while, that PED is going to go into a rip. But I don't think there's a preponderance with a particular treatment, or I don't think I warn the patient that badly that it's so dangerous. We just treat them. It's just a very small risk that the RIP may occur.
Now we have to session as our time is over. I would like to thank Dr. Huang, Dr. Prasad, Manish, Ajay Dudani, and Raja Narayanan and Naresh for the very fine session. Thank you all very much.